Okay, thank you once again. I'll be talking about autofluorescence techniques, and I must thank Pradeep again, because we always make good features of these imaging modalities, and it was really hard work to find some problems with these modalities, and I had to read, and it really enlarged my knowledge base. So we'll be talking about autofluorescence techniques, which again our availability is a bit limited, and hence our understanding is also limited. So just a little background about autofluorescence, which was first described by Delory in 1988. It is a non-invasive modality of detecting fluorophores. Now what is a fluorophore? It is a molecule which absorbs the light and then gets excited and again releases the light. Lipofuscin and melanolipofuscin are the major fluorophores in the retina. A2E is a major component of lipofuscin. So this modality provides us unique findings which are not seen on other imaging modalities. So there are basically two types of autofluorescence. Commonly referred to or traditional autofluorescence is called shortwave autofluorescence, in which we have excitation light of 488 nanometers and absorption spectrum of 500 to 520 nanometers. On the other hand, we have another kind of autofluorescence which is called near infrared autofluorescence or long wave autofluorescence, in which the absorption and excitation and absorption spectrum are at a longer wavelength, while short wave autofluorescence mainly assesses the lipofuscin deposition. Near infrared autofluorescence assesses the melanin deposition. Near infrared is very uncommonly used and is mainly used for research purposes. I will be limiting my talk to traditional or short wavelength autofluorescence. Just a word about how to differentiate between these two. In short wave autofluorescence, the center of the macula is dark because the lipofuscin here is minimum, and it is absorbed by the melanin which is available there, so we get hypoautofluorescence. On the other hand, melanin is maximum in the center, and therefore the center of the macula is hyperautofluorescence on near infrared autofluorescence. Now significance is that it provides us insights into the metabolic state of the retinal pigment epithelium, while hyperautofluorescence indicates increased lipofuscin accumulation. A decreased FFA represents absent light signal. Now interpretation is very simple. Black is dead and bright is dying. So on autofluorescence imaging, when you see a black, that means that part of the RP is dead or is being blocked, and the surrounding white or bright area is dying. It is something like to a forest fire, where it is black, where it is gone, left the damage, that is the RP which is already dead, and the edges which are bright is about to die. So it does tell us about the partial physiological status of the retinal pigment epithelium. Now how does a normal autofluorescence image look like? Disc is usually dark, and it is due to the absence of autofluorescence material. Retinal vessels appear dark because the absorption light thrown on the retina is absorbed by the hemoglobin. Fovea appears dark due to absorption of blue light by the xanthophylls. Parafoveal area shows increased autofluorescence, and this again decreases towards the periphery. Now sometimes you can confuse these FA pictures with FFA pictures, fluorescent pictures from autofluorescence, but remember, disc is white and the vessels are also white in fluorescent angiogram, while in autofluorescent the fovea is dark, vessels are dark, as well as the disc is dark. But this is again not 100% true, because as I'll be showing you later, this can depend on the various types of cameras. So we have different types of machines for autofluorescence imagings. Most commonly available is Fundus Camera or CSLO. Fundus Camera is what we usually have in terms of Zeiss or Topcon. They use bandwidth filters. That means a range of light is thrown and a range of light is captured from all the layers of the retina and the eye, and hence the contrast is poor. So these would also include the autofluorescence emanating from the cornea, autofluorescence emanating from the lens. On the other hand, CSLO, which is predominantly available in Spectralis platform, in certain forms of TOPCon as well. The blue light, a monochromatic light, is thrown and it is captured back only from a single layer of the retina, and hence the contrast is much better. Nowadays we have optos with us which can also capture autofluorescence images, but the wavelength used is of this slightly longer wavelength, and hence it will give you a partial autofluorescence from lens as well. How do we evaluate? Remember, hypo-FAF, as I told you, is because of the loss of the RP or reduction in RP lipofuscin. It can also occur because of the increased melanin content of the RP and absorption of the extracellular material, cells or fluid which are anterior to the RP. So anything which is in front of the RP is also going to lead to hypoautofluorescence because of the blockade or shadow effect. On the other hand, hyperautofluorescence is seen when there is excessive lipofuscin accumulation, and then when there is increased fluorophores anterior to the surface of RP. This is also seen in optic nerve head drusen. So this is just to give an idea. This is a patient, same patient with AF, adult form of vitelliform dystrophy. We can see a deposition which is much better seen on a CSLO image as compared to a traditional fundus camera where the contrast is much lower. Also, if you see, because the contrast is lower, these machines try to increase the brightness, because of which the disc also becomes slightly bright. So if you see the hyperfluorescent material much better seen on the CSLO, and disc can be little whitish on the fundus based cameras. The third platform is optos, if you see, which can again give us insights into various disease mechanisms. So if you see, this is the central part which is seen on autofluorescence, and we can see this is a patient with Stargardt, central hypo, and then peripheral flex. The central flex are hypoautofluorescent. As we go to periphery, the flex become hyperautofluorescent. But when we see the total image, we can see that the posterior pole shows significant hyperautofluorescence, and if we see only the posterior pole, then we can miss the contrast between the center and the periphery, which can give us various insights. Now there are various applications in our clinics which include ARMD, CSC, retinal and choroidal dystrophies, drug toxicities, posterior uveitis, and certain special scenarios like drusen and astrocytoma. Now we are all aware, I will not be showing you where it helped us, but I will showing you certain cases where it can be challenging. So this is a patient, typical patient with the buried optic nerve head drusen. We can see the disc looks edematous, but when we go to autofluorescence imaging, we can see the drusen are showing as hyperautofluorescence, and we can easily diagnose this patient as disc drusen. Now this is another patient. We can see there is a mulberry fruit-like lesion which is hyperautofluorescence, and again we are sure that we are dealing with the case of retinal astrocytic hamartoma. But see this lesion, this is on the disc, and just looking at the autofluorescence probably will diagnose it as disc drusen. But when we go to the color picture, see there is a huge amount of large mass there which is lying. Now this picture clinically would correspond to a retinal astrocytic hamartoma, or hamartoma which is lying on the optic disc and not optic disc drusen. So again, my purpose is to tell you that do not interpret a single image on its own, and every modality has its own limitations. So we can argue between a diagnosis of astrocytoma or drusen, but going by the size and other features, it was a astrocytoma. This I have already told you, you must consider the whole clinical picture of the patients. And another disadvantage of AF imaging is that the same lesion can have different appearance on autofluorescent imaging. So consider this PED. This is a patient with CSR. We can see some pigmentary changes, and there is a PED which is lying infranasally in the fovea. Now if you see on OCT, we can clearly see the PED and subretinal fluid. We go to autofluorescent imaging and we see that we cannot see PED at all, or if we see carefully, we can see this round thing here, and this probably corresponds to the PED, which is hyperautofluorescent with some flecks of hypo, and this is the tract of the fluid which has led to increased RP deposition of lipofuscin. Now this is another patient. If you see the OCT scan, there is a PED here, there is a PED here, and this scan shows it beautifully on the OCT scan. Now we go to AF images and we see that the temporal PED is hyper autofluorescent, sorry. But the one which is embedded in the pigmentary changes due to CSC has a mixed type of autofluorescence. This part is little hypo, while this part shows stippled hypo as well as hyper autofluorescent. This is not the end of it. You go to another type of PD, again a serous PD. So this is a patient who has a PED here and a PED here. So the upper scan shows the OCT shows this PED like this, and the lower scan shows this PED in this image. So basically we have two serous PEDs, one is pigmented, one is non-pigmented, and if we see carefully, this pigmented PED corresponds to this one and the RP is missing. So this is being seen as a hypo-autofluorescent PED, but the temporal one is being seen as hyper-autofluorescent because of the chronic lipofuscin deposit. Coming to the last PED again, there are two PEDs again, here and here. This is the OCT scan vertical and we can see a PED. But if you see these two PEDs, these are seen as hyperautofluorescent because of the chronic nature. There is increased lipofuscin deposit, and these seen as hypoautofluorescent. So the basic idea is to tell you that on autofluorescent, it is not important to make a diagnosis based on just autofluorescence. You have to consider the various modalities and make a diagnosis in toto. This is again a patient of CSC. If you see carefully, we are all familiar. This is a RP tract which is beautifully seen, and this is what I was showing: fire in the forest, central where it is dying dead, and the periphery bright where it is about to die. So we know that RP tract are seen in CSC. Now this is another patient on autofluorescent imaging. Sorry for the picture quality because of the cataract. Patient media was a bit hazy, but if you see, there are RP tracts, and when we did a fluorescein angiogram in this patient, the RP tract was much better visible, but on ICG we could see a large choroidal hemangioma. So again, do not go by a single imaging modality. Do consider your clinical examination as well as the other imaging modalities. Then there are various problems which arise in patients of when we are considering autofluorescence. These are various artifacts and signal noises which can come. I'll show you some effect. This is a patient of angioid streaks. We can beautifully see angioid streaks, a young patient, so you can have a very good contrast. But as we move on to an older patient, because the lens autofluorescence is also included in a fundus based camera, we see that the contrast becomes poor, and hence it is very difficult to interpret the image. But the same patient or a similar patient, I would say the angioid streak patient here, I did another time on a subsequent visit. If the pupil is small or the flash is low, so you can get two different kind of images. So if the pupil is small, you will get less brighter image. If the pupil is large, we will get a more brighter image. And similarly, if the flash is strong, you will get a brighter image. So do not interpret it as a hyper-autofluorescent or this one is hyper-autofluorescent. We have to compare the various images and then interpret. And this is on ICG, this is based on CSLO image. You can see the picture is much brighter and the contrast is much higher. So you cannot compare the images taken on one machine platform on the another platform. So CSLO images and the autofluorescent images taken on traditional fundus cameras cannot be compared. Few other conditions. This is a patient with subretinal hemorrhage. Of course, it is blocking. We see hypoautofluorescence, and on OCT we can see there is subretinal bleed. But see, this patient has a hyperautofluorescent lesion, and when we see on fundus photograph, we see that there is a yellow lesion. So obviously, young male hyperautofluorescent yellow lesion, we might consider a diagnosis of Best vitelliform dystrophy. But if you see carefully, there is a rim of hypoautofluorescence, and on this image we have subretinal bleed. So basically, we have a patient with subretinal bleed, young male who had post-traumatic injury and had a subretinal bleed. So to Again, a lesson learned, fresh bleeds will block fluorescence, while the old bleeds, alter blood, will be hyper-autofluorescent. So what gave away in this particular patient was hypo-autofluorescent ring and unilaterality of the lesion. So it is much clearly visible here, central part is altered, peripheral bleed. On autofluorescence, we can see central part is hyper, while the peripheral is hypo. We can have bleaching effect. If you take on the images again and again, the fluorescence can change. Just to give you an example, central image was taken using a 30-degree lens, which is square image, and then a 50-degree field. We can see the central part appears hyper. Actually, it is not hyper. This is just the bleaching effect of the previous image. Intraretinal fluid can again appear hyper-autofluorescent, not very clear. Just to show you the difference between the CSLO based image and the Fundus Camera based image, it appears hyper-autofluorescent, but if you go on to a CSLO based image, we can typically clearly see that a cystoid edema would lead to a hyper-autofluorescence. Sometimes autofluorescence cannot give you a good image, as you see here, but you go to color image, the images can be quite striking. We are dealing here with a patient of Svensson chorioretinal dystrophy. To summarize, the protocols for acquisition need to be defined and standardized for doing autofluorescence. Differences in acquisition techniques could affect the findings, and FFA is very, very sensitive to media opacities. And FFA alterations may also be due to various dynamic processes, that is light intensity, level of dark adaptation, and photoreceptor bleaching. Thank you.